Hey, good afternoon. We're going to go ahead and get started.
You can move up close to the mic.
Okay, thank you. So, welcome to the scariest presentation of the day. It's after lunch, and I tend to speak in a slight monotone. So, you guys are going to help me out a little bit and ask questions as we go, and hopefully stimulate some conversation. I have some slides, kind of with some questions on them that we can kind of have discussion towards the end of this presentation. So if you're in this room, you should be here for the kind of crisp and context, how to get data within your EHR. If you're here for care alerts or PDMP or any other topic, you're probably in the wrong room. So cool. So kind of the general purpose of this conversation, again, is I want to talk about what CRISP has done over the past year to get information into the workflow. Within EHRs, we primarily focused on hospitals, and then kind of what we're looking to do over the next year, the next upcoming year. It's hard to think any further than 3 to 6 months from now, but we'll set some lofty goals. And then also to get some feedback from everybody in the audience about what we have done and what we should do and things like that. And just to introduce myself, I'm Mike Banfield. I work at CRISP. I worked at CRISP for the past a little over 3 years now. I've worked with a lot of folks in the audience, I see, and I manage development efforts for the in-context delivery. So our CRISP integration goal, how we're getting information into the EHRs, ultimately we are less interested in if we have a long-term vision, we want to migrate away from this concept of a portal where a provider has to go outside of their EHR, their native workflow that they operate in every day, use a separate set of credentials to log in and search for a patient again, and look up information. What we'd like to steer towards is practices and hospitals have made investments in these tools, in these EHRs, and we see it as our job as an HIE to get information into those tools as seamlessly as possible. And so just trying to focus around what is that information that we should be delivering in there. So we have two strategies. One is incorporate these discrete pieces of data into the native workflows. So if you're an Epic, that might look like a best practice advisory. If you're in NextGen, it might be trying to be a part of the prescribing workflow to tell you that this patient may have had a prior overdose or this patient has prior controlled and dangerous substances dispensed for them. And then the strategy two is we can build apps, we can have SSO, and that's kind of more of a crisp curated presentation. And so for this conversation, I'll touch on both, but I'm going to lean heavily on strategy one. And so these are some kind of open questions about data ingestion. I want folks to kind of look these over, and then at the end of the presentation, we'll come back to these, and as a group, we can kind of go through these and give some thoughts, and I'm going to lean on Craig a little bit to help out in that discussion. So just kind of generally, what data is most important to providers? We started pushing some data out, and I'll kind of show you the metrics. And then how do we get that data? And then what workflows should we leverage within these EHRs? Can the EHR even accept this data? I know that some EHRs are maybe ahead of the curve on things like Smart on Fire and other stuff. And then if we are delivering this information, are people actually looking at it? I think is a very important question that we need to continue to ask ourselves. And then just one other note, I manage a development team. I tend to steer more technical. So if I get too technical, feel free to pull me back and ask me to explain stuff. And Craig is also here to kind of help out with that. So understanding what's valuable. Over the past year, we've really focused on these items on the screen. Care alerts. I hope by now everybody's pretty familiar with the concept of a care alert. It's a kind of piece of high priority information that one provider wants to communicate to another provider, whether that be a primary care physician communicating that to an ED physician, or a care manager who wants to communicate that outwards. The PDMP data, the Maryland PDMP data, I know that there's been several sessions on this already, and we have the state mandate, and we're all pretty familiar with that now. And so delivering that information in as seamless of a workflow as possible has been a big focus of ours. Overdose alerts, this is a relatively new piece of information. This is a fact that a patient has had a prior overdose event. And we're getting that information from some dromic surveillance feeds with all the facilities that we're integrated with. We're working very closely with the Maryland Department of Health on this initiative. Infection control, again, another area where we're working very closely with the Maryland Department of Health. This is communicating information like a patient has a drug-resistant infection or Zika or TB or C. diff, something that a provider might want to know before treating the patient. Advanced directives, this is something that we're working closely with Maryland and West Virginia on to communicate the fact that a patient has an advanced directive, and then if the patient does have an advanced directive, a link to that so the provider can actually go and look at the document. Care teams and care prior visits. So who's working with this patient? Does this patient have a care manager or a primary care provider? If so, how do I get a hold of them? And then prior visits. What were the prior visits for this patient? Whether that be hospital or inpatient, kind of ED, or even ambulatory. And we're also working with the Maryland EMS to get kind of those emergency encounters in there as well. So I'm going to kind of the next 3 slides. Yes, sir.
How does, in general, CRISP fare with HIPAA?
With HIPAA, we follow.
If we need patient information from the hospital, medical record, I need to make that patient sign release of information.
That might be a question. You want to jump in?
Yeah, I'll do this one. So it's a great question. So first, Maryland is an opt-out state through the HIE. So all patients have the right to opt out of sharing their data through CRISP for treatment purposes. The exception there is the prescription drug monitoring program data, which is mandated by law. The way in which data is allowed to flow in concert with HIPAA and Maryland regulation is essentially that every treating provider who wants to share data with or receive data from CRISP has to sign a CRISP participation agreement. That agreement includes a business associate agreement, which is how we get the data, and then we essentially share the data back to providers that have a treatment relationship. And so that's why you don't need to sign extra releases of information.
So how is the patient data put into CRISP?
So there are a variety of ways, and kind of the chart on the left.
Without patient consent or with patient consent?
So with patient consent. So every CRISP participant is required to update their notice of privacy practices that patients should be reading. They're required to have CRISP flyers available to inform them of opt-out. And quite frankly, we kind of expect and hope that providers with the patient relationships share things about how their care and data is being handled. We actually, and I might poll the crowd, we've had an idea to, in addition to updating the NPP, which is a 14-page document that you sign once and no one ever reads the whole thing, to maybe on the signature page, also putting 1 or 2 sentences that says, your health data may be shared for a variety of purposes in order to help facilitate care coordination across providers. See page 12 for details, or click crisphelp.org.
So it doesn't need a separate consent?
Correct. There's no need for separate consent.
Who initiates the original signature for this? The original release for them to sign this?
So it's essentially the practices. So CRISP has business-to-business relationships with the treating entities. Yep, and we have that with all the hospitals in Maryland, all the hospitals in DC, about half in West Virginia, and we have data sharing agreements with Delaware, parts of Pennsylvania, and parts of Virginia.
Answer this question. As
Sure.
part of our business agreement with CRISP, we agree that on our privacy notices, we have a little blurb on there that says we participate in CRISP. If you don't want to do it, here's how you opt out.
Yep.
And in the past 4 years, I've had one person
That's right.
say to me, I want to opt out.
Yeah. And I will let Mike actually give his presentation, but we have very low opt-out rates. I think that's partially because as a patient, you kind of expect your treating providers to talk to each other. But we do think there are certain people who want to have information and want to have the opportunity to opt out. So I do think the prevalence of the fact that you're sharing data is probably important.
Do you have to be specific in making it clear on the consent form that CRISP
Yes, yeah. So we have specific language we require in the NPP, and the opt-out flyer has specific language, and our website, which is updated actually with more kind of patient-friendly information.
Yeah, so the topic of consent is very important to us, and kind of as it relates to the infrastructure. When every time we receive a query or every time somebody's looking up a patient, we're hitting against like a consent service on our end. Is this patient opted out? Is this patient not opted out? If that patient is opted out, you will see no data for that patient. And so that's kind of how that applies to our infrastructure. So kind of our infrastructure, these next 3 slides, I'm going to talk a little bit about kind of the direction we're heading. Historically, CRISP as an HIE kind of operated in this model where we contract with vendors. They sell us a platform or like this monolith that kind of does everything that an HIE should do, and we become a reseller of that service. CRISP over the last year has really tried to take control back with our own development and kind of move towards a microservice approach. And a microservice, it sounds technical, but all it is this piece of technology does one thing. This PDMP microservice is responsible for storing PDMP information and responding to queries for PDMP information. And so you can kind of carry that model forward. Alerts, it kind of does similar things. And so that's how we're moving forward. We have lab services, we have radiology services, and so we're being very specific. And what this allows us to do is return sub-second response times. You can ask us for information and we'll return it very quickly. And why this is important is a lot of these queries are becoming automated as we get deeper and deeper into the EHRs. There's workflows that just kind of trigger queries in the background, and we need to be able to respond to a large amount of queries relatively quickly so it doesn't impact the user experience and CRISP doesn't become the dependency. And so if you look at the impact of kind of that effort on the right side on this graph, everything that's shaded is kind of a provider going out to a portal and interacting with our services, doing a query against ULP or MRF. And then the dotted line is these kind of automated queries, these API calls. And you see that we had to add a different axis for that. That kind of operates in the millions rather than the thousands. And so in the last year, that's kind of shot up like a hockey stick. And our infrastructure has enabled us to deliver PDMP information and care alerts in a way that we couldn't before. And so just kind of different representation of that architecture. On the left-hand side, that's what we were operating on, this kind of monolithic thing that did everything. And we're moving towards this granular microservice concept to enable us to do kind of more granular workflows and tie in deeper with EHRs. Again, another representative architecture. And all this is to say that everything goes through an API gateway, which is just kind of our common access point, where all the hospitals will interact with CRISP, and it will apply things like those consent rules. It'll determine who has access to what information. If a hospital service, like an unknown party, cannot hit us and get information. And we also implement things like throttling, where if we're normally seeing 10,000 queries in an hour from somebody, and all of a sudden we're seeing 120,000 queries in an hour, we will shut that connection off. So just to kind of represent this, PDMP data returned kind of per week over the last year. It's grown pretty dramatically. I think in January, groups like University of Maryland, and I see Paul Thompson and Anna Schoenbaum here, and Johns Hopkins, I see Michael and Omar here, started interacting with our PDMP microservice and pulling information into the prescribing workflow so that they can actually see the fact that this patient has controlled dangerous substances prescribed to them by other physicians. And then on the alert side, the alerts information that I went over earlier, kind of a more gradual climb, but again, we're seeing dramatic growth in how this information is being delivered around the state in the last year as well. So this next set of slides, I kind of want to give some examples on how we're integrating information into different EHRs. I don't have Cerner on here, but I can kind of talk about Cerner. I see Bill Thomas from LifeBridge here. So I'm going to talk about strategy 1 primarily, incorporating data elements into the native workflow of providers. And so the ways we're doing that today, PDMP delivery into systems like Epic, into Doctor First, into NextGen, and into PCSI. We're in the prescribing workflows of each of those applications. Best practice advisories within Epic. That's a pretty unique thing to Epic, but we're going to be generalizing that strategy across all EHRs. That's one of our efforts over the next year. Bidirectional immunizations with Cerner, NextGen, Epic, Meditech. I'll show you what that looks like in a moment. CCDA delivery. These are giant documents of XML that we send back. Has a whole bunch of clinical information in it. And then Meditech integration. So I think there's been a couple other PDMP presentations already, but I just want to give a little bit of a timeline on kind of what the workflows look like over the last, if it's 2018 right now, this would be the last 6 years. So in 2012, if a provider wanted to interact with the PDMP, that would mean going out to a separate portal, using a separate username and password, logging in, searching for the patient again, and then looking at data. That can take several minutes, and if a provider doesn't have a whole lot of time to see the patient, that can be pretty invasive. So we tried to improve that with single sign-on. A single sign-on passes provider context, and it passes patient context. So that allows the provider to not have to log in again, not have to search for the patient again. They just kind of land on the screen, and then they can see PDMP information. That was kind of a big step forward, saving several minutes. You still have this feeling of leaving your environment and your workflow and going somewhere else, though. And so in 2018, I think we took a huge step forward, and we started incorporating PDMP information directly into the prescribing workflow. Somebody is ordering a controlled dangerous substance, and that PDMP information will show up right in that workflow. Before moving on with that order, you have to acknowledge that this patient has controlled dangerous substance dispensed for them. And then the other way that we're doing that is our Smart on Fire app, which is kind of an exciting tech thing that everybody's geeking out about. But we present information kind of within the workflow there as well. And I'll give an example. Another thing that we're delivering are care alerts. Care alerts we're kind of delivering in a couple different ways. It's really by any means possible. So we're packaging them up in a clinical document and sending it back to groups like Epic. Cindy Gingrich has done a great job leading the Bay Area Transformation Partnership forward, kind of coordinating the sharing of care alerts between University of Maryland and Anne Arundel. And so this is an example of what a care alert might look like within Epic. And so again, it's something that a provider sees, doesn't have to go out to CRISP to fetch. I might ask, or kind of put Paul Thompson on the spot a little bit, if he doesn't mind, to kind of talk about the PDMP implementation within University of Maryland Epic system. And feel free. Yeah, hey, you can come up here. You can sit there. It's however. Sir.
How secure is CRISP, and how secure is going to be CRISP when you integrate over the network?
I would say we're incredibly secure. We're high trust compliant. We operate, most of our back end is in the Azure infrastructure. I would challenge you to find an Azure data center, a Microsoft data center. Once you find that data center, try to get in the data center. And I don't think you'll be able to. If you have further security questions, I can pull in our Chief Security Officer. Paul, you want to go ahead?
So I'm Paul Thompson from the University of Maryland Medical System. And so what we did is, actually my director had a vision way before the mandate for PDMP data. And the prescribing workflow is we need to go from single sign-on and to actually bringing PDMP data into the provider's workflow. And so we worked with Epic and CRISP and came up with a standard way of doing it. We looked at several different methods and came up with NCPDP, a standard dispense history interface. Once we got the standard, then what we did is CRISP has a monthly Epic user group meeting. And so we leveraged that user group meeting to take a look at the technology and the requirements. On the right side of the screen, you'll see actually the Epic sites that we include in the design session. And what we did is we looked at the requirements, should be non-intrusive. We had to look at where in the workflow we would trigger a query to CRISP to get the PDMP data. We already decided that we're going to use the NCPDP standard. The documentation requirements, because we had to actually prove to the state that we were auditing the provider actions, that they were actually reviewing PDMP data. And then also CRIS had documentation requirements so that they could audit on their side. And then we actually did a collaboration for the actually data agreement that we all had to sign when we shared data, or got the data from CRISP. And then we documented to make sure there was repeatable implementation through all Epic sites. So it took us, University of Maryland came up first, and then after that, so it took us about 6 months, and other hospitals could do the same process in 2 because we documented and shared it. And so Chris really helped us share that design and benefit all Epic hospitals. Thanks.
Paul, I appreciate you coming up here. I think that's a great example of how user groups have allowed us to move some of these initiatives forward. And so kind of what a user group is we get a like-minded group of folks, so everybody using Epic in Maryland as an example, together on a call once a month, and we kind of talk about the initiatives we'd like to move forward. And last year, one of the initiatives that user group wanted to move forward with the help of Paul was getting PDMP information into the prescribing workflow. And so we kind of came up with a strategy, came with a plan, worked with the EMR vendor, and were able to make that happen. And so CRISP is kind of taking that user group strategy. We started with Epic, and we're spreading it out to other EHRs. And so Michelle Rubin, I'm not sure if she's here, but Michelle Rubin, colleague of Craig and I, is leading those efforts, kind of starting those user group conversations. We have a Cerner user group, we have an ambulatory user group, obviously we have our Epic user group, there's a behavioral health user group, and there's now a Meditech user group as well. And so if you're interested in being a part of those user groups, please let one of us know. So to give an example of kind of what Paul talked about and what it looks like, this is PDMP information. Obviously this is test patients showing up within the prescribing workflow within an EMR. For bidirectional immunizations, this is kind of goes 2 ways. Immunizations are being delivered to CRISP, and we're sending those to the state immunization registry, Immunet, from hospitals. And we're also delivering immunizations back into the workflow. And so we're doing that currently for Cerner, we're doing that for Epic, we're doing that for Meditech, NextGen, and Harris Public Health. And so all these things that I'm talking about, kind of delivering information into EMRs, I'm showing some examples. We'd love to be able to do this with kind of every EMR that's represented in this room. I know that's a huge goal, and not every EMR is going to be there, but we do want to really push this strategy forward. Here's an example of PDMP information in NextGen. Yeah, go ahead.
Just on that note, for practices that have smaller EHR vendors, what's sort of the conversation or the pushback that you hear as far as how much work is required on their end for their developers to come up with a way to integrate this versus how much CRISP provides? That's
a great question. I think so the question was, how much pushback are we getting from some of these smaller EHRs when we present kind of approaches like this, the fact that we want to deliver information into their EHR. We try to nullify that a little bit by using standards, and so that's standards like Smart on Fire, that's standards, like kind of anything that HL7 has said is a standard. It's kind of, on the CRISP side, it's our goal to support. So we can at least make life a little bit easier for those EHR vendors. Sometimes we still get pushback, and so that's the benefit of the user group. If we can get a whole bunch of individuals from that EHR, and then we can get that EHR on the call, and everybody can kind of represent their interests collectively, all the customers of that EHR vendor to the EHR, that can really help move the ball forward in a way that CRISP is unable to alone. And so we kind of need to be operating collectively here. And so I think this next-gen slide is a great example of that. We pulled together a next-gen user group to get PDMP information into next-gen. When CRISP approached next-gen and said, hey, we want to do this, they said, great. When we pulled together all the next-gen users and asked them to kind of help us with this, we saw this happen within a month. Next-gen was able to make incorporating PDMP information into the prescribing workflow happen in a very short time, which was awesome to see. And I don't think that would have happened without the user group. Kind of strategy too, I'm just going to touch on it, but what you see on the screen is our Smart on Fire app that we've talked about. I think Ryan mentioned it this morning, and you might have heard about it in other places. This is leveraging an HL7 standard, Smart on Fire. Fire is a fast healthcare interoperability resource, and it's just kind of a standard way to get access to applications like this. It's a provider-facing tool, and the tool is meant to sit within the EHR, kind of take up a portion of the screen. So the provider now has the ability to document within the medical record while looking at information from CRISP. They don't have to hop out to a different environment and kind of try to remember what they saw and then go back and put it in their notes. It's just right there for them. And so this is something that we're continuing to put efforts behind to develop, include additional pieces of information. I'll talk about that here in a moment. So what are we working on? What's it going to look like in the next several months? One of the near-term deliverables for us right now is our Meditech strategy so far has relied on third-party vendors to kind of help us with that integration. And what we're looking to do is kind of bypass some of those third-party vendors and have that capability ourselves. So for delivering data into Meditech, this is kind of what it looked like. It's called CRISP stuff. In prod, it's not going to be called CRISP stuff, but right now, that's what it is. And so this would allow a provider to see information that CRISP might have on this patient on their status board. And so we're using something called the Meditech monitor interface. This is from conversations with Meditech. We're working closely with Meditech users and with Meditech themselves to figure out this workflow. My colleague Jeremy in the back is kind of the technical engine behind all of this. And so what this looks like is that Meditech will send an ADT to CRISP. They're already sending ADTs to CRISP. There's no extra work from the hospital. CRISP is taking that ADT. It's kind of the fact that a patient was admitted. And we're hitting our own APIs. As Ryan mentioned, APIs are kind of the things that make all this happen. And then we're packaging that up into a way that Meditech wants to receive this information. We're packaging it up into an ORU, and we send it to a specific endpoint for Meditech, and that allows the information to present in this manner, kind of on that status board. And so that is meant to inform our provider, hey, CRISP has information. What information do they have? And so we're kind of specific about it. And that might be enough to inform the provider, okay, I should go into the unified landing page. I should go check to see what other information CRISP has or try to drill deeper into the documents. And so it's meant to inform kind of the actions that provider takes when interacting with CRISP tools. One of our other strategies over the next several months is kind of around the best practice advisory and the CDS hooks strategy. CDS stands for clinical decision support. And so clinical decision support, that would be something that CRISP is helping to provide. And so this is the fact that a patient may have an overdose is really one of the first things that we're trying to move forward. And so we want to generalize that into other things like infection control. Hopefully informing a provider that this patient may have a drug-resistant infection or other things that physicians and providers might find valuable to know about a patient within their workflow. And so I kind of put a diagram. This is from the CDS Hooks website. This is an HL7 standard, and so that's kind of why we're going towards it. It's a standard that we believe EHR vendors will support. I know Epic is working to support it, Cerner is working to support it, and several of the other smaller EMR vendors are working to support it. And so what this workflow looks like is we get some information from the EHR vendor. We process that information, and we're probably interacting with our APIs in a very similar manner that I showed on the Meditech screen. And then we are sending data back, and it can be just information, or it could be a suggestion like remove this medication. Or we could open our Smart on Fire app and say, look at this information. And so those are things that we're continuing. Like we want feedback. What's the best pieces of information to be delivering in this workflow? And so hoping to talk about that more here in a few moments. And so this is what it might look like in Epic. This is a overdose best practice advisory. This is something we're currently working closely with Anne Arundel and University of Maryland on. If you represent an Epic facility and you would be interested in making this happen, we're ready to test with you now. And so Epic triggers a query to CRISP, and we send back a payload that they're expecting that informs them that this patient has an overdose. If the patient doesn't have an overdose, there's nothing to click through. We're not going to tell the provider, hey, the patient doesn't have an overdose, because then that's just one extra thing to click through. Around the Smart on Fire app that I showed, we want one of our additional goals is to incorporate more information into that application. And so that might be the ability to communicate in your match. It's going to be incorporating lab information, radiology information, images if the patient has the image, if you can see an x-ray. We're going to be incorporating diagnosis information, the fact that an advanced directive exists, transcribed documents, and then SSO. So you can go from here to the ULP if you want to see more information. So some of the other things that we're focused on, if you're representing an Epic facility and you use, if you're familiar with their tools, Canto or Haiku, that's kind of the tablet or the cell phone based versions of Epic. We're looking to get that same app that I just showed onto those platforms. We're also going to continue working with Cerner to get our in-context app within the Cerner app gallery. Those are active conversations right now. We're in the Epic App Orchard. We're going to be within the Cerner app gallery. We also want to work with other EMRs. We've had great success with the hospital EHRs. We want to be moving out into the ambulatory space, so the Athenas, the NextGens, Allscripts. We want to get information flowing into those applications, and we're hoping that the ambulatory user group will help us get there. Sir?
How about eClinicalWorks?
eClinicalWorks as well, yes. We actually ran into eClinicalWorks at an HL7 presentation. We were demoing our Smart on Fire app. They saw the presentation and they were encouraged by it, and so Ryan Bramble started having some conversations with them.
For what it's worth, we all know EHR vendors, and so multiple conversations from multiple people tend to be the best way to drive action.
Yeah.
And we can have all the conversations in the world with ClinicalWorks, just like we did with Epic. We're not the customer; they don't care about us, and so that's part of the reason it's so nice to have groups of like-minded folks with the same priorities.
So again, if anybody's interested in joining kind of one of these user groups to kind of help be one of those voices at the table when we're talking to the EMR vendors, please let us know.
I think eClinicalWorks needs a user group. But I also wonder if you guys can provide a language, because I will just say that I've just been like striving for a single sign-on for a couple of years, and they will say to me, well, Chris hasn't provided a specification. And I'm like, I'm pretty sure they have.
They
You know,
do.
right? So
They do.
So I just get caught as a customer. So if there's like a language that you can provide, that maybe even suggest a language for the conversation for those of us who aren't super technical, but know that there's something fishy, you know, that would really help. I totally do agree with the leverage of user groups. So sometimes a user group can speak collectively, like we are 30 practices, you know, do something for us. I find that that's the way that they respond. But it's also hard because it's a trust relationship that gets hit when we like get stuck, and we get stuck.
Mm-hmm. Yeah, it seems like a user group would really be helpful there. Ma'am.
How would you know as an individual provider when the EHR that you're using is starting to go forward with this?
I think that might be another benefit of a user group, to kind of stay tuned with kind of progress that CRISP and the EHR vendor are kind of having together. Like, these are the things that we're working on this month, and this, like, kind of what the priorities might be. Additionally, I know Ryan Flood, who you've seen kind of running around the conference, she's really working to kind of send out more of this information to CRISP users kind of on a regular basis. Like, hey, we went live with a Smart on Fire app with Cerner. That's going to be something in an email. Things along of that notice, just kind of digests. And then I know on our website we're looking to get this information as well. Sir?
Yeah, are you guys going to provide, because there are some of us that I work at a bigger group and I have a solo practice. Have you guys tried to do you have a list of attendees and the EHR that they use kind of help to create those user groups?
We can do that. Yeah. So we just set up the essentially everybody except for the Epic user groups. We did some blast emails. We got a bunch of volunteers, but we can post. Let me think about how to post online, like a link for interested folks or something.
Yeah.
Yeah,
That's a good idea.
Hi, I have a question. Are there any plans to, we use quite a bit of CRIS services, but speaking of the query portal, it helps us because it tells us where the patient was and I can get labs, but I can't really get documentation. I can't really get encounter notes and things like that. Is that in the plan?
You're looking maybe more for like the transcribed documents or things like that, the transcription notes?
I can go out to some places for discharge notifications from our area hospital. I can do that. But if I'm looking at a hospital that is not affiliated with us, so to speak, but I can see through the portal that my patient went there, I can't really get any information.
That's actually a really great point. I've kind of spent the last half hour or more talking about all the information that we can send out and how we can do it, but we're really only as good as the information that we receive. And so if there are pieces of information that you would like to see that you're not seeing, tell us. And then I think that's another benefit of these groups. And so it's kind of bringing together the whole kind of CRISP community here. If one facility is not sharing information that you find valuable, I think finding a polite way to inform them that we would really like to see that information. I saw this one back here, and then I'll hop up.
Along the same lines, but then when you do something to the documents and you try to open it, some of them are very formatted very bizarrely, where you get this very narrow column and you're just kind of reading through it, and it's very difficult.
2 letters on each line, yeah, I've seen those.
Yeah.
Understood. I'll highlight an initiative that I think Hopkins is leading, really just among the Epic groups initially, and then we're hoping to expand it out to the other EHR vendors. Looking to kind of standardize the clinical document that's exchanged, where things live within that clinical document, so that when you do receive it within your EHR system or you are looking at it on the portal, the information can be rendered in the right spot. And so if we can, I think the thought right now is if we can get that done with Epic, and then we can kind of broaden it out to the other EHR vendors, we'll have a specification that we can kind of centralize around. I know this is something that nationally, other HIEs and even non-HIEs, just one facility to another facility, is really a struggle. Just kind of, what's the standard for communication sharing?
Yeah. One more question, it kind of related this. So we do have a single sign-on within our EHR.
Okay.
The Genius Bar, is that what you call it? Would they be able to help? We have seen a couple instances, not enough to really cause concern, but when using a single sign-on, it is not the patient that we're signing on to. So is there, who would I speak with about that?
So that's one of those patient matching items, and so I think one of the focuses around single sign-on is right now you launch directly to a patient, and so we're going to continue to do that when we have high confidence of a match. One of the things we are working on is if we don't have high confidence of a match, we're going to launch you to a screen where you can kind of look for the patient that might be the right one.
So the short term is if you call the support number, or there's a feedback button in the unified landing page where you can enter secure feedback. We do troubleshoot individual instances of potential MPI, like matching issues. And we can go through and merge identities, separate, kind of figure out what happened.
And you said that feedback button is in the ULP?
Yep.
Question on the MPI. Is it possible for users to get your MPI that CRISP uses internally so that we can build our own match and help out, de-differentiating?
But that's a service that we're asked about pretty frequently. Right now, kind of with our licensing, that's not something that we can do. We can't kind of provide our master ID out in that way. I don't know. Do you have any other
Yeah,
thoughts?
I mean, part of the challenge, so aside from kind of our inability to act as an MPI on behalf of the state, essentially, or everybody within the other problem is that our enterprise ID changes as patients merge, get separated, get added. And so if we were to give you kind of a monthly batch of our identifiers, they might not all be correct anyway.
Yeah, so there's a risk that I would be assigned a CRISP ID of 123. And so that CRISP ID might be accurate today, and then tomorrow, for whatever reason, like we get other records in, and so we're continuing to rematch and refine. I might become 457.
Yeah. A similar but different service that we've heard, especially from payers, is using our APIs to receive updated demographic information. So if a patient has new phone number, new address, new last name, we can provide our most recent demographic data back to you to help essentially clean up your own patient demographics. So that might help depending on your kind of ultimate goal. Yeah.
That also could be a problem.
Yeah, it goes both ways.
That's why you need it.
Sir.
Patients with multiple charts in the CRISP, only one of them has adequate information.
Right.
So if you search on a patient, it will appear, in 5 lines per. There's only one of them.
Yep. So the way we solve that problem in the unified landing page for PDMP is that you can select multiple identities and view all the drug data within a single view. We couldn't do that on other kinds of views within ULP because they lived in that kind of monolithic thing that Mike talked about. As we move to new configurations of the microservices, I think, and I'll make sure Ryan doesn't shake his head at me, that we can merge other data like we do for PDMP. We'll have that kind of flexibility.
Ma'am.
So today, the primary dialogue has been around hospitals' access and providers' access to information. I'm going to look at the Healthcare Coalition for our hospital. And we had early on begun to discuss how home health agencies and SNFs would be able to have access. And I know we had some barriers because of the concept of a patient versus a resident, et cetera. Where are we with that?
So any treating provider that establishes a relationship with a patient can get access to CRISP. We have almost every SNF in the state submitting data to us. They could also get access. I would say it has been less sticky in that kind of industry. Likewise with home health, and quite frankly, home health I think is a great use case, especially as they get the hospitalization notifications and then don't go home. Instead they go support the hospitalization. So they can have access. The trickier one is care management entities essentially acting that are not covered entities, that are not providing treatment, but are acting on behalf of another group. And that's where patient consent comes in, and I can go through details maybe another time. But yeah, any treating provider, skilled nursing facility, home health, hospice, they can all get access.
So that issue which we had heard from our SNFs that they weren't able to get access because it's residents and they would have to get signed.
No difference. No difference. The tricky, maybe borderline use case is continuing care retirement communities or independent living facilities. So if you're in a congregate housing setting that is not a nursing home, not a treatment provider, we can't give access to medical records for people who, to non-medical people. But if you have an on-site medical director who is treating those residents, then you could get access through the director. So there's nuance, but it's solvable.
And to give a little bit more insight into that dynamic, Craig operates a lot more on the policy side. I operate a little bit on the technical side. And so as long as somebody says, yes, we can share this data with this group, I get really excited by graphs. I go from the lower left corner to the upper right corner.
He just hits accept, and I assume that sends all the data everywhere.
Right. So I'm building these great tools. Let's use them. So as many of these kind of new use cases as we can do. That's encouraging.
And I'm sorry, we have one more minute, so maybe I will say Mike and I are here and available and have cards and contact information. But we have one more.
That's right, because on her question, access to CRISP, does that include out-of-area providers? Because we have a provider who has recently moved to Delaware, is no longer in the CRISP area, and was told that she was going to have to pay $19,000 to connect to CRISP. I don't know who she talked to.
So, very briefly, HIEs are different in every place. DC is very similar to Maryland because essentially CRISP operates both. West Virginia is very similar because we support the infrastructure. Delaware is a different HIE with different policies, payments. We do have policy that allows non-Maryland providers to get access if they're within a certain mileage of the border.
15.
So she would be able to get access directly through CRISP. Yep.
Cool. So again, Craig and I will be up here. I really appreciate everyone coming to the presentation and coming out today.
Thank you.